Yeah, we need some theme music.
I know, right?
Yeah.
We'll have somebody write us some theme music. Here comes everybody.
Well, I
Fast
can
and
write
Furious.
the music. I'll write the theme song for the next talk.
Okay, that's a deal.
Yeah, we're trying to improve our production value, so we're going to add music next time.
Yeah.
So welcome everyone. Thanks for joining us on this dark, rainy evening. So I'm glad it's not like a sunny summer day. Otherwise, we wouldn't have so many people signed up. So thanks for coming. And the topic of today, presented by the Burnaby Division of Family Practice, Leona and myself, what you should know about heart disease. So I'm going to cover the broad spectrum of heart disease, including heart attacks, angina, cardiac rhythm problems, changes in your heartbeat, valvular heart disease, and I'll also give some tips on the end about what you can do to make sure you understand medications that are prescribed to you and the key questions you should ask any doctor, especially if you're seeing an unfamiliar doctor who doesn't know you well. Some key questions just to make sure he or she answers everything to your satisfaction so you can give informed consent and make the best decisions, which is a big point of our topics for empowering patients. So the Empowering Patients program, for those that are new to our webinars, is a public health education program sponsored and organized by the Burnaby Division of Family Practice. So Leona and I have been doing this for about 8 years. And initially it was live talks in the community, which was wonderful to meet all of you in person. But since the start of the pandemic, we converted to webinars. So it makes it accessible to people all over the place, as long as they're able to log on. So I know that's hard for a lot of seniors that don't have access to the latest digital communications. And we cover a variety of topics. Oh, and then this is a reminder. I've dedicated this talk not only to my dad, who's turning 93 a month from now. He's a great role model that we were made to move and to keep on moving, to stay healthy, active mind and active body. But it's also dedicated to my mom, who passed away next month, April 2003, will be the 20-year anniversary of her passing. She died suddenly and unexpectedly from a cardiac arrest. So we suspect it was from a massive heart attack. She had a few risk factors, although she was very fit and active. In fact, she was at the community center doing her exercise when she collapsed, and she was quickly attended by the lifeguards at Eileen Daly Pool, who did everything that they could, and the paramedics, but they couldn't revive her. So I'm dedicating this talk to my mom. And part of the reason why we're here, as family doctors, we care about our patients, but we also care about our community. And that's what the Burnaby Division of Family Practice has shown. Family doctors working together in our primary care network, which involves the many organizations, including the health authority, the hospital staff in our inpatient hospitals, all the residential care centers, all of the partners that look after all aspects of physical and mental health for every member of the community, and how we've worked together to look after everyone, because it takes a village to look after every individual in the village. And are caring for the future, because eventually I'll retire someday, but no time soon, because there's a reinvigoration of family practice, as you heard, and we'll be getting more family doctors joining the Burnaby community and other communities throughout the province. And family doctors are being more fairly rewarded for the many long hours, which is wonderful. So more younger doctors will turn back to longitudinal family practice. Longitudinal means care over a lifetime, but I think family practice is more, it's latitudinal because it covers the breadth of a patient's life and all aspects of their life, their social, family life, and what matters to them, in addition to their physical and emotional health. And there's so much breadth in our relationship and the trust and confidence that we build over time. So it's more than just the passage of time, but it's the breadth and depth of our relationships with our patients. And that's what's kept me going for over 30 years with my 2,500 plus patients. So we care about our patients, our community, and the future. So today I'll be talking about how the heart works, just because it's a simple small organ, but actually more complex than you think. And the different types of heart disease that I shortly outline, but I'll give you some details in plain language so that it's more understandable. To let you know the symptoms of these different types of heart disease and to figure out if you're at risk for heart problems in the future. And then what you can do to reduce your risk and its complications. So I start all the talks just reminding you that healthcare is more than the acute care in the hospital. And it's more than all the community care and the chronic disease management that family doctors and other community health providers give to you. And the person that provides most of your healthcare is not myself or a nurse practitioner or your pharmacist. It's you, of course. The best predictor of your future health are the habits you practice every day. So real healthcare is self-care, and we're here to support you so you have the resources that you need. And the point of the Empowering Patients program is to give you a good foundation of self-care. So I consider the 4 foundations of looking after ourselves is what you eat, what you put into your body, and that includes not putting in things that are noxious or unhealthy for us. What you do, physical activity as well as rest, such as sleep, how you feel, emotional well-being, and how you connect, our relationships. So 4 key aspects of your well-being of self-care: what you eat, what you do, how you feel, and how you relate. So we've had topics on each of those that are available on video and my slides and the key points. So you don't have to take notes yourself. There's a key points handout. I believe Leona will put a link in the chat, as well as you can see on our Empowering Patients website on Divisions BC/Burnaby, our Burnaby Division website. You can see that under patient information. So we also talk about improving communication with healthcare providers, medical ethics, what you should know, healthy physical activity, and chronic conditions such as diabetes, high blood pressure. This month, heart disease, and next month, lung disease. There's also a presentation on screening tests in a larger video. So those of you that haven't seen your doctor since the start of the pandemic, it's good to look through that little slideshow as well as the video, because I go over the symptoms we should watch out for in different systems of the body that should prompt you to make a visit to a healthcare provider. And the first stop would be your family doctor. And there's a great production we had on the keys to positive change, how to change those bad habits into healthy new ones. Also look at the Burnaby Division of Family Practice menus. It talks about the primary care network as well. So what do you need for good self-care? You need that basic knowledge. You need unbiased information. So we don't make any profit from these free talks, and it's their evidence-based information that we're sharing. We're not trying to sell anything, unlike a lot of the things you see on the radio, television, and on the internet. So most of some of these parts are kind of my opinion, but I'd see health as not the absence of disease, and healthcare is not the treatment of disease only. So health is not the absence of illness or disease, and healthcare not just their treatment. But I believe that we each have a positive potential, a unique potential in our life. That's our talents and experiences and our passions. And it's our duty to realize that potential and to help others achieve theirs. So our potential doesn't mean perfection, but it's guided by your personal values. Okay, so let's start with how the heart works. So the heart, I was going to pull up my heart if I could find it. I brought it home from work here. So your heart is not this heart-shaped character that you saw on Valentine's Day. It's kind of heart-shaped, but it's about the size of your fist. And the heart is actually made up of 2 sides. So the right heart and the left heart. And each side of the heart has an atrium a little chamber, and a ventricle, a larger chamber. So we say the right atrium, the right ventricle, the left atrium, and the left ventricle. And I'm going to go through how the blood pumps through the chambers of the heart and why we have two sides of our heart. And the heart is not just a super pumping machine. It's also electrical. So it's a strong muscle that pumps in coordination, but it's electrical signals that causes contractions. That's why it's not a good idea to get electrocuted. So as I mentioned, each side of the heart, the right and left, is made up of an atrium and a ventricle. So you'll see on the diagram, on the left side is actually the right side of the heart. So you see blue because that's blood that does not have oxygen. So that's why when we're cyanotic or cold, the veins look a little bit more blue. So veins are more the superficial blood vessels that you can see. They don't have any pulse, but that's where we take blood if you're getting a blood test. Like for example, at Life Labs or at the hospital. So it's from the veins that we remove the blood. So it's not going to be spurting up into the air. The blood vessels where you feel a pulse, like your radial pulse or the carotid pulse here, those are the arteries. So the left side of the heart pumps oxygenated blood because that's blood that's been infused with oxygen after passing through the lungs. So the blood passes from that. You can see the left atrium on the right side. That's actually the left atrium into the left ventricle. And from there, it's pumped into the aorta to all the organs of the body, importantly, your brain, all your other vital organs to your extremities. So that's the big purpose of the heart, to pump blood away that's oxygenated to all the organs of the body. And that blood returns through the veins, where you see the blue, the vena cava. It returns back to on the right side, the right atrium, which pumps the blood to the right ventricle, and the right ventricle pumps the blood to the pulmonary vein, and that goes to the lungs, where it's oxygenated and comes back as healthy, bright red blood, ready to be passed on from the left atrium and ventricle to the rest of the body. So it's a very coordinated effort, and it's because of the electrical signals generated in the right atrium, our normal pacemaker, that allows the atria and ventricles to contract in coordination. So again, the right atrium receives the blood from the rest of the body through the veins and pumps that blood to the right ventricle, which pumps it into the lungs. And then the lungs turn that blue blood into red blood, oxygenated blood. And then that left atrium receives that oxygen-rich bright red blood from the lungs and pumps it into the left ventricle, the big chamber that pumps it in to the aorta and to the rest of the body. So these four chambers are pumping in coordination because of the coordinated contractions. So, and we'll go into details of what things can go wrong and how to identify them and how they're treated. So the big question, are you at risk for heart disease? Well, yes, we all are. So family history or genetics may indicate those that are an individual's at greater risk. So, but that family history doesn't mean you're condemned to have a heart attack at the same time your father or mother did, but it tells us which risk factors we should be watching out for and how we can change things with our daily habits. For example, I'll go over the common risk factors, but if you had a relative, first-degree relative, like a sibling or a mother or father that died prematurely from a heart attack, for example, under age 65, risk factors could be smoking, could be high blood pressure, diabetes, or very high cholesterol. So we can search for those risk factors in yourself to see if we can modify them when you're young before it causes changes in the blood vessels that feed the heart. So the four main types of heart disease that I'll go over today are: number one, coronary artery disease; number two, valvular heart disease; three is arrhythmias or irregular heart rhythms, more to do with the electrical conduction; and four, heart failure. I think it's so important that everyone understands these four main types of heart disease, because so often when we meet new patients and take their medical history, or they give their history in the emergency department, they might say that their father, mother, grandparent died from heart disease or a heart attack, but not knowing for sure exactly what kind of condition they had. So at the end of this evening, you'll have a good understanding of these 4 different types of heart disease. So you can know that they have different risk factors, different symptoms, and different ways of treating them. So let's start with coronary artery disease. So the coronary arteries, like in the picture, are the blood vessels that arise from the aorta. So remember, the aorta is that oxygen-rich blood from the ventricle that's being sent to all the vital organs. So that's your brain, all the organs within your body, your extremities, but the other important organ is, of course, the heart. So the heart itself receives that oxygen-rich blood through the coronary arteries, which are just on the surface of the heart itself. So you can see that those red blood vessels on the bottom right-hand corner of the diagram. So you can see that they're just on the outside. So they actually pass on the outside surface and then bring blood to all the muscle of the heart. So if we cut off the blood supply to the heart muscle itself, it can no longer contract normally. So coronary artery disease is some narrowing or damage or plaque and cholesterol that builds up inside those arteries. So when a coronary artery is completely blocked, for example, say there's a blood clot in that little blood vessel in the surface that feeds a portion of the heart, the muscle downstream is starved of blood, and if it's starved long enough, that muscle will die. So that's actually a heart attack. So it's where the blood supply is blocked off to the muscle downstream. So there's typical symptoms and there's atypical symptoms of a heart attack. When that artery is not completely blocked, but just partially blocked, so it's a little bit narrow, like a clogged pipe. So the blood downstream isn't totally starved, but it has a reduced amount of blood, less than it needs to function normally. And the result is what we call ischemia, so a decreased blood flow. And the symptoms that are experienced most of the time with ischemia is chest pain. So chest pain that comes on when the heart's trying to work harder. For example, when you're exercising or when you're under psychological stress and the heart is trying to beat faster. So when the muscle is working harder, needs more blood, but the blood vessel is too narrow to supply it. It's like taking a shower and not getting enough water. But instead of just not getting clean and rinsed off, instead you're feeling chest pain. And then once that demand reduces, when the heart rate slows down, then the chest pain disappears. So the typical symptoms of ischemia or angina is the sensation is chest symptoms that come on when you're exercising or when the heart's beating fast for another reason, like when you're stressed, and then relieved when the heart rate's back to normal again, when you're at rest. So here's a little picture. So at the top is just a normal artery where it's all clear. And then the second one in the middle is an example of atherosclerosis that some people call hardening of the arteries. It's actually when that nice soft blood vessel becomes hard and brittle, and the lining on the inside, we call the intima, is clogged up with cholesterol and then sometimes blood clots. So if you have a narrowing of the artery from different risk factors like smoking or diabetes and high cholesterol or high blood pressure, all it takes is a little blood clot to clog that narrowed opening to turn angina into the symptoms of a heart attack. So let's go over the symptoms of a heart attack. It's also called an MI, or myocardial infarction. So myocardial means the heart muscle itself, and infarction means cutting off the blood supply. So you could feel it typically in the chest, but it can also be felt in the throat, in this area, or in either arm. We often think the left arm, but sometimes it could present in the right arm as well. It could be felt as pain or sometimes just pressure. So the classical is a squeezing type pain, like someone sitting on your chest. It's often associated with nausea and a sweat, like a cold sweat and queasiness. That's why a lot of people might think they have a stomach problem or heartburn when they're getting actually a heart attack. And with a heart attack, often there's difficulty breathing. So if you, the classical thing is to see someone holding their chest because they're feeling some pressure, some nausea, they're breaking out in a cold sweat, and they're having difficulty breathing or breathing really quickly. So those are the classical symptoms of a heart attack. So often easily spotted. So these are the most common symptoms, the classic heart attack symptoms that we might see in a man, but it can present in different ways in different conditions. Women often present in atypical ways. That's why heart disease is often misdiagnosed or missed altogether in women presenting with heart attacks or angina as well. Also, people with diabetes often have an atypical presentation of angina as well as a heart attack. The symptoms of angina or cardiac ischemia, that means decreased blood flow to the heart muscle, is similar pain or pressure, often in the chest, the throat, or the arm, that is worsened by anxiety or physical activity. So again, both conditions increase the heart rate and therefore the work of the heart. And so the heart muscle demands more, but if the arteries are narrowed, they don't get enough, and the symptom would be pressure or pain in these areas. So we often will ask someone with chest pain if it's worse when they're anxious. And that's not saying that we're thinking it's in their head or that the anxiety is simply causing the symptoms. It's just that anxiety and stress can put demands on the heart by making the heart beating faster. Just like when we have a panic attack or when there's a stressful situation, then our heart starts pounding faster. So that's why we ask about anxiety, not that it's something that the patient's just worried about and it's not a real problem. But anxiety is equivalent to physical activity for increasing the heart rate and the work of the heart. So silent ischemia or atypical angina or heart attacks are more common again in women and people with diabetes. So some people might have the same thing, decreased blood flow, or even a heart attack and not have the same symptoms. So this chart shows you the differences in men and women, but I'll kind of go through this again. So again, the typical symptoms of a heart attack, the classic symptoms are chest pain or discomfort, maybe a rapid or irregular heartbeat, feeling dizzy, faint, or lightheaded, breaking out in a cold sweat, often with nausea, maybe stomach discomfort and shortness of breath. So some of it could be nonspecific and mistaken for gastrointestinal problems like heartburn or an ulcer. The symptoms in women can be chest pressure, but it could also be, a heart attack could also present as just extreme fatigue for no other reason that can go on for several days or even a week if we're missing it. And anxiety or disturbed sleep because of the change in the sympathetic tone of the body. It could be pain in the back, in the arm, in the neck, or even the jaw. Often there's nausea or stomach upset, often there's shortness of breath. So you can see that if someone's not getting clear chest symptoms, the other symptoms might be mistaken for someone just being under a lot of stress or being tired or having COVID. So what we need is a high index of suspicion. And by the end of this talk, you'll know what the risk factors are for heart disease. And so someone with several risk factors or family history, if they present with these symptoms, we're going to investigate and make sure that it's not a problem with their heart when it could be other things that are less serious. So atherosclerosis, again, is the narrowing of an artery. So when we have narrowing of the arteries that lead to muscles like your lower limbs, we call that peripheral atherosclerosis or peripheral arterial disease, or PAD, PAD. The symptom would be pain in the calf when you're walking. So a lot of people might mistake this as just sore muscles. But if you have decreased blood flow, circulation to your legs and to your feet, the symptom would be when you're walking a certain distance or walking uphill, you'll get this increasing pain in the calf. Medical term is called claudication. And that's because the muscles of the legs are working harder, demanding more oxygen-rich blood. And if the arteries are too narrow, it's not supplying enough of that oxygen-rich blood for the muscles to function. So we get pain in the calves. And then when we stop walking, demanding less, then the pain goes away. Start walking again, it comes back. So those are the typical symptoms of PAD, peripheral arterial disease, from narrowing of the arteries going down the legs to the feet. Some people might have narrowing of the arteries that are supplying the intestine. So abdominal pain that comes on when you're exerting yourself or after a big meal that requires lots of blood flow to the intestine, you can get abdominal pain. So those are also examples of the pain of a lack of blood flow or ischemia. If we have decreased blood flow to the brain, that can cause strokes if there's a complete blockage of an artery, like the carotid, or the smaller blood vessels, like the middle cerebral artery, can cause a stroke to the brain tissue downstream. Or TIAs, transient ischemic attacks. That's where there's partial narrowing and then a return of blood flow. So temporary neurological symptoms, like sudden difficulty speaking, that comes back. Or an area of weakness or loss of vision, that comes back again. So there's many other things that could be confused with it, but someone with risk factors that we'll mention, like high blood pressure, smoking, age, and family history, then we'd have a higher index of suspicion, as doctors would say, for investigating, checking it out. If we have decrease or blockage in the blood flow to the arteries supplying the eye, that can cause sudden blindness. And as we mentioned, claudication is blocking of a blood vessel that goes to the leg. And if untreated or ignored, that can lead to gangrene and amputations of toes or even feet or legs. And atherosclerosis, if supplying the blood vessels to the kidneys, that can cause a decrease in kidney function and eventually kidney failure. That's why in people with risk factors for hardening of the arteries, like people with diabetes, we commonly do a urine test that checks for the leakage of protein in the urine. And that's because if there's leakage of, if there's damage to the blood vessels of the kidney, that protein will leak out and we can detect it in the urine. So it's a good marker for the risk for hardening of the arteries elsewhere. So these are the key risk factors to have in mind. Some of them, many of them are modifiable. So number one is high blood pressure. Number two is diabetes. The next is high cholesterol. Fourth is family history, and the fifth is smoking. And of course, the sixth risk factor is age. So if we're all lucky enough to live to our 80s and 90s without getting cancer or an accident, we do have atherosclerosis to the little blood vessels in our brains. We have narrowing of the arteries to our extremities and to the heart as well. So it's not unusual. And a usual cause of death in our 80s and 90s might be a heart attack that comes unsuddenly and is the cause of our death if we're in our 80s and 90s. So let's go through all the risk factors that we can identify and modify. So number one is high blood pressure. So typically we define it as a blood pressure in the office repeatedly over 140/90. If you're measuring your pressure at home, the similar borderline blood pressure would be 135/85. So if you're just below 140/90 in the office, it is a higher than average blood pressure. So a good average blood pressure for most people is 120/130. But it's at this level above the level of 140/90 in the office repeatedly is a risk factor for developing heart disease or peripheral atherosclerosis. So most adults should check their blood pressure annually. If you happen to have a drugstore that has an accurate blood pressure monitor that fits your arm, that gives you an idea of what it might be. A lot of people have automated blood pressure machines at home that you can buy from the drugstore. And there's certain brands that are more accurate than others. If you look at the hypertension.ca, it gives a list and serial numbers of those machines that they've checked out and are found to be accurate. If one of my patients is relying on home blood pressure readings, once we've diagnosed a higher office blood pressure reading, I usually ask them to drop off the machine so I can check it after hours or on the weekend to see how close it is to the gold standard mercury blood pressure monitor that we have in the office. And if it's accurate, then we let them rely on that for the home readings. And of course, during the pandemic, very few people have actually seen their family doctor. In fact, when patients come in, get surprised that I've talked to them or done video chats with them over the past 3 years, but actually haven't seen them and checked their blood pressure in over 2.5 years as well. So high blood pressure could be treated with diet, with cardiovascular exercise, like running, jogging, swimming, exercise, or medication, limiting sodium or salt in the diet, and limiting alcohol. So the second risk factor is diabetes. So that can be screened in people at higher risk. So there is the CAN-RISC calculator for calculating your risk for diabetes. You can go to the Canadian Diabetes Association website, diabetes.ca, or you can just ask your family doctor if you're due for a blood test to check for diabetes. So the hemoglobin A1C is a non-fasting test that gives us kind of your average sugars, and that's a good screen. There's also the fasting glucose, and confirmatory test would be a glucose tolerance test where they give you sugar to drink and checks 2 hours what your response is to that sugar. People who have established diabetes are considered to be at high risk, like over 20% risk for having a heart attack over the next 10 years. So even though you haven't had a cardiac history, if you do have a diagnosis of diabetes, you're considered to be at higher risk. And that's why we want to treat all the other risk factors and monitor if you develop even the atypical symptoms of chest pain or possibly heart attacks. That third risk factor is high cholesterol, particularly the LDL cholesterol. That's the unhealthy one from saturated fats in the diet or from genetics. And a high cholesterol could be treated with diet. Exercise raises the healthy HDL cholesterol that protects our arteries, and medications, commonly statins and others, that can drastically lower the LDL cholesterol. And the family history we're looking for is at least one first-degree relative. That would be a sibling or child or parent, because they share 50% of your genes. So if any of your first-degree relatives have had angina or chest pain that's related to the heart, or heart attacks under the age of 65, or surgery to treat those conditions. And smoking. So smoking, all the toxins that are within cigarettes, so not so much the nicotine, which is the addictive part, but all the toxins from tobacco, they cause damage and oxidation to the inside of our blood vessels, making them more brittle, more likely to get clogged up or to be narrowed. So talk to your primary care health provider if you're ready to quit smoking, but you can also check quitnow.ca. So that's the provincial site for tips and support for quitting smoking. So what tests can we do to check for heart disease if it's suspicious from our family history and any of those symptoms that we've described? Well, one is the electrocardiogram. We might call it an ECG or an EKG. So both are the same. EKG is kind of a German form, but what most doctors use, using a K instead of the C. The exercise treadmill test or the stress test, the MIB or MPI, that's a nuclear test that shows the uptake of blood within the heart muscle, the CT angiogram, and the typical angiogram under X-ray guidance, injecting dye into the arteries. So an EKG or an electrocardiogram is a tracing. So as the leads are put onto the heart, it takes less than 2 minutes to do. And it shows the conduction of the electrical signal throughout the heart. So we're trained for many hours as medical students to interpret the electrocardiogram so we can identify if there's an irregular rhythm, or if there's signs of ischemia, decreased blood flow, or signs of a recent or previous heart attack as well. So a lot of you might have smartwatches. So I have an Apple Watch that I actually use all the time, partly for myself, but largely because I will get patients coming in with symptoms that are suspicious for an irregular rhythm. And to confirm it, I could just wipe off my watch with alcohol, put it on my patient's wrist, and then let's see if I can get this on the screen. And then within 30 seconds, we'll be able to generate an electrocardiogram, a 1-lead electrocardiogram. So I can see there the normal conduction of waves. So I don't have atrial fibrillation, but then I can print that onto my phone and then interpret to see if there's signs of other rhythm problems. The exercise stress test or the exercise treadmill test is a relatively sensitive test, but not 100%. It's about 70% sensitive. So this patient is describing those typical symptoms of ischemia of the heart. So when they're exercising or when they're really stressed and the heart's beating fast, they're feeling squeezing pain or pain in their throat or their arm or similar symptoms. With exercise, that's relieved by rest. Then we might put them through the exercise test, which is supervised by a cardiologist, just in case. And that gives us a good clue of someone so if that's abnormal, we know we need to investigate further. But if it's a negative and we want to look a bit further, there's another test called the MEBE or nuclear stress test. And that has an over 90% sensitivity of picking up narrowing of the arteries as well. So it uses a teeny bit of radiation and it shows us what the blood flow is in the heart with something called persantine that simulates exercise. So that gives us a good idea if there's what we call reversible ischemia. But if someone actually has had a heart attack, it may or may not show that ischemia. The classical CT angiogram is actually a CT scan with contrast, and it can show us the actual arteries without actually going into the arteries physically with catheters. So it does involve radiation, but it can tell us if we have a high index of suspicion that this person may have heart disease, then we will, the cardiologist can go on to order this test. Most family physicians are not able to order this from the hospital. That's because it requires an internist or cardiologist to evaluate the individual. And the classical angiogram is when we put catheters into the blood vessels, inject dye, and actually visibly see where the blood vessels are narrowed. So how do we treat coronary arteries, these narrowing of the arteries that supply the heart muscle themselves? So one is angioplasty. Another is a coronary artery bypass graft. And then of course, medications, and then strict risk factor management, like helping the individual quit smoking, optimizing the cholesterol levels, managing diabetes, and controlling the blood pressure. So if someone is diagnosed with coronary artery disease, it's not unusual that they may be on 4 or 5 or 6 medications, in addition to lots of support and coaching to improve their lifestyle. Angioplasty is actually putting catheters into the blood vessels and stents. So not a stent, which is like a temporary job, but stents, which are little tubes, metal tubes that are put into the blood vessel to keep them open. And often they may dilute a little bit of a medication that keeps them open at the same time. So those are stents that open portions of the artery that are narrowed for a small segment. But if a large portion or almost a whole artery is clogged up and blocked, then we need to do a bypass, like a detour. So a blood vessel, in this case a vein, is taken from the right or left lower limb and grafted onto the outside of the heart to bypass the blood vessel that's narrowed. So the bypass is a vein that's used so that blood can flow around and still supply the heart muscle downstream. So if you suspect you may be having a heart attack, call 911. So don't wait for it to get better. Don't wait until the morning. I probably wouldn't bother to call the doctor on call, even though he or she will respond as quickly as possible, even on a long weekend. If you suspect a heart attack or have potential risk factors, or you're just older, you it's better not to wait, even if it could be heartburn, even it could be something that you ate, it's better to call 911 if you have risk factors, because they can send the appropriate ambulance to see you. The paramedics may be equipped to treat you on the spot, and you'll be taken to the hospital that's most available and ready to treat you. Because the longer we have a cutoff of the blood supply to a heart muscle, the higher risk of death or permanent damage to the heart. So again, I want you to study those symptoms, both the typical and atypical symptoms of a heart attack, so that you can memorize those or have them handy. All the notes, these slides, and the key points handout I put together, and Leona has made them available on the Empowering Patients website. So if you go back to the Divisions of Family Practice page on Empowering Patients, you can look at the talk and search for other resources, and then you'll have all those resources available. So our next type of heart disease is valvular heart disease. So these are the valves that prevent the backflow of blood between the chambers. So there's 4 of them, the heart valves. So there's the mitral valve, the pulmonary valve, tricuspid valve, and aortic valve. So if you look at the little diagram there, or take a peek inside my own heart here. So when the atrium contracts, we don't want the blood to flow backwards from the ventricle back into the atrium again. So to allow a one-way flow of blood, each of the chambers has supposedly a one-way valve, but those valves can become narrowed or leaky over time. Or it could be that's just the way the valve is genetically, congenitally narrowed or leaky. So the mitral valve is the valve between the left atrium and the left ventricle. So that prevents backflow between the two. So the atrium contracts, blood passes through the mitral valve on the left side of the heart to the left ventricle. The left ventricle contracts and passes blood through the aortic valve into the big aorta to the rest of the body. So that prevents the backflow back into the heart. And then when blood returns from the rest of the body, it enters again the right atrium. The atrium contracts and passes blood onto the through the tricuspid valve into the right ventricle. The right ventricle contracts, passes the blood through the pulmonic valve into the pulmonary arteries that supply the lungs. So it prevents a nice, orderly one-way flow of blood. But just as you suspected, things can go wrong with the valves too. So a valve could be narrowed, or we call it stenotic. An example is mitral stenosis. But the most common valvular heart disease is aortic stenosis. A valve could be floppy and allow backflow, or leaky, and we call that an incompetent valve. An example is tricuspid or mitral regurgitation. So again, aortic stenosis is the most common abnormality of the heart valves. And when the aortic valve is narrowed, as you can see on the image in the top right, it shouldn't be that narrowed when it's open. That decreases the blood flow that goes into the aorta and supplies the rest of the body. So the heart is not able to pump out all the blood to give enough to the rest of the body. So it can be clogged up most commonly is by calcification over time, and that occurs as we get older. So aortic stenosis can often present as we get older. It gets worse over time, and we need to follow closely with either CT scans or with echocardiogram sound waves. And then some people have a different type of aortic valve. So most aortic valves have 3 leaflets, but some people are born with just 2 leaflets, what we call the bicuspid aortic valve. And the bicuspid valves are a little bit more prone to cause aortic stenosis as we age. And a less common form is rheumatic fever, which is from having a strep infection when we're younger that wasn't treated with antibiotics. The bacteria can seed onto any valve and actually cause narrowing over time. And as you might imagine, since the aorta supplies blood to the rest of the body, the common symptoms might be shortness of breath, chest pain with exertion, and sometimes passing out because the blood's not getting up to the brain. And if those symptoms are getting worse over time, it can lead to backflow into the heart because the heart is pumping against a really closed valve, and that can lead to heart muscle fatigue, or what we call heart failure. So the symptoms of valvular heart disease, again, can include fatigue, especially with exertion, shortness of breath when you're doing physical activity, even doing the laundry or walking up the stairs. It could be chest pain. And when the doctor listens to your heart with a stethoscope, we actually hear a flowing sound, which we call murmurs. So normally when we listen to a normal, healthy young heart, we just hear the sounds of the valves opening and closing. So a lubbed up type of sound. And a murmur is kind of a blowing type sound that we hear at different stages between those two opening, closing sounds of the valves of the heart. So that's one of the things we're listening to when we're listening to the heart. And then valvular heart disease, if we suspect it from symptoms or from our physical examination with the stethoscope, can be more definitively diagnosed with an echocardiogram. So that's a specialized type of ultrasound using sound waves right over the chest wall or the abdomen to show the movement of the valves of the heart. So I think we have enough time for me to actually show you what an echocardiogram is like. So I'll just take my handy little ultrasound. So can you see this here? So this is called the butterfly, and it's an example of POCUS, point of care ultrasound. So if you're in the emergency with a cardiac condition or even a pneumonia, the emerge doctor might take one of these out and then use it over your chest and look at a monitor and to see if it's something acute. So he can actually make a lot of diagnoses that normally would take many hours to do and waiting for a technician to do the ultrasound. So it involves no needles or anything, but lots of gel on your chest or abdomen. So I'll just try not to pull my shirt off here and then see if I can give you a few images, not as nice as a full-fledged echocardiogram, but you can see my heart in action right now. You can see the valves opening and closing. And fortunately, I don't have any stenosis or regurgitation in my heart. So that's the amazing thing with new technology, that we can do a lot more than just listen with our stethoscopes. But ultrasound technicians train for many years, and they're very specialized in echocardiography. And a good echocardiogram would take a long time to do, and they do specific measurements to measure each of the valves and the degree of blood flow. It can also calculate the function of the heart, how well the heart ejects its blood through the left ventricle. So we treat valvular heart disease with careful monitoring, periodic echocardiograms, and if a valve is critically narrowed or leaky, surgery can be performed, and it's not always open heart surgery. It can actually be done through non-open heart techniques, going through the blood vessels. So some types of valvular heart disease require preventive antibiotics. So prophylactic antibiotics doesn't mean antibiotics before intercourse, but it means antibiotics before certain procedures that can spill bacteria into your bloodstream. And commonly, a source could be your mouth, doing dental procedures, or procedures on your bladder, or orthopedic procedures can allow bacteria to enter the bloodstream. So we commonly use amoxicillin an hour before that procedure to prevent the spread of bacteria that could seed onto the heart, into the valves. So the third type of heart disease are irregular rhythms, arrhythmias. So arrhythmias are abnormalities in the rhythm, the electrical conduction of your heartbeat and the contractions of the heart. So if the heart is beating too fast, we call it tachycardia. If it's beating too slow, we call it bradycardia. And you can get extra beats that come in early in the cycle that we call premature beats. And we have pauses or delayed beats. So your heart should normally be beating like a metronome. So when you're running, it's allegro, so it's beating fast, but regularly. And beating slowly when you're resting, that is still regular, just like a metronome. But if you're having beat, beat, and then a pause, that could be something like a heart block, or what we call pauses. Or if it's beating regularly and then you get an extra beat inside, those would be called premature beats, and they can come from the atrium or the ventricle of the heart. So generally at rest, our heart rate ranges from 60 to 100, and a rate of 100 or more at rest is considered a tachycardia. And a heart rate less than 60 is considered a bradycardia at rest. And of course, with exercise, it can go much, much faster. But if you're checking your pulse now and your heart rate is, say, 50, if you're young and you're a trained athlete and trained for triathlons, that could be quite normal. But if it's going lower than 50 or you're feeling lightheaded or dizzy, it's important you get checked with a physician. One arrhythmia, ventricular fibrillation, is when the big chamber of the heart that's supplying blood to all organs of the body, including the brain, is beating totally irregularly. We call it fibrillating. So when the heart muscle is just doing this instead of just contracting, ejecting blood naturally. So it's fibrillating, that blood's not moving anywhere. And then you're going to collapse and be unconscious. So that's the case where an automated defibrillator will detect that ventricular fibrillation from the electrical signal and then automatically charge, and that electrical signal that it sends into the chest might make the heart revert back to the normal sinus rhythm again. So that's why those automatic defibrillators are there in case someone suddenly collapses in a public place. Atrial fibrillation is an irregularity of the heartbeat that doesn't have any pattern. We call it irregularly irregular. And it's due to the atrium, where you naturally have your normal pacemaker that sets the pace of the heart, either fast or slow, depending on your activity. With atrial fibrillation, there's an irregular electrical pattern to the heart, and in the atrium, like that ventricular fibrillation, is just shaking less rather than contracting into the ventricle to allow the ventricle to contract. So when it's fibrillating, the blood doesn't flow properly and the blood can clot. And this could be a risk factor for a stroke. If the heart is fibrillating, the blood just pools into it. And then when there's a normal big contraction, that blood clot can go into the ventricle and then up to the aorta to the brain. So I swim at all the public pools in Burnaby, but one afternoon about 10 years ago, a young guy came out of the steam room when I was just stretching in the hot tub after my 80 lengths of front crawl. And he asked me, why does our blood get thick as we get older? And I said, our blood doesn't get thick when we get older. Where did you hear that from? And he said, well, I just got out of the steam room with all the old men and all of them are on blood thinners. So that what they were all on were something like Coumadin or warfarin that thins the blood because they actually had atrial fibrillation. So these individuals are often given a blood thinner so that blood within the atrium doesn't clot and then cause strokes. So that anticoagulation, the original medication was Coumadin or warfarin. Some of you might know as rat poison because it requires careful blood monitoring so that we have an effective dose without having too much of a dose that causes bleeding. Because if we give too much warfarin or Coumadin and don't monitor it, it can cause bleeding from the gastrointestinal tract, or it can cause a bleeding stroke in the brain if someone has a fall or injury. There are novel anticoagulants, including Xarelto or Eliquis, and those do not require the same kind of monitoring. So it's a specific dose based on age and kidney function. So these blood thinners or anticoagulants reduce the risk for what we call ischemic strokes from blood clots that can go into the blood vessels to the brain, like the carotids or the cerebral arteries. But of course, they increase the risk for bleeding strokes, hemorrhagic strokes, and gastrointestinal bleeding. So the decision to use anticoagulation is made by the patient based on their individual risk factors, with a health professional. So we weigh the relative risks and benefits, and there's a specific algorithm we use depending on their age and multiple risk factors. But if you are taking a blood thinner, make sure you recognize the signs and symptoms of bleeding, like increasing bruising that seems abnormal, headaches that seem unusual, abdominal pain, blood in the stool, or throwing up blood would be indications that your warfarin or Coumadin dose might be too high, and might be indications for going to the emergency. Arrhythmias, or irregular heart rhythms, can also be treated with rate-controlling medications. Pacemakers that are implanted underneath the skin with the leads inside the atrium and the ventricle, and a procedure called catheter ablation. So note the pronunciation is ablation. So some people say ablation, but it's ablation, like nation. So a catheter ablation is a procedure where we actually put in a little catheter through blood vessels into the wall of the atrium, and we actually burn or scar that area with and block out the electrical pathways that are causing the irregular rhythm. So it's often done through blood vessels, sometimes through the esophagus, which is really close to the heart as well. So arrhythmias may cause chest pain or shortness of breath or palpitations or fainting spells. But many patients don't have any symptoms at all. So they might come in, I'm checking their blood pressure, I'm noticing the pulse is irregular, in fact, irregularly irregular. So I will clean and slap on my Apple Watch and do a quick electrocardiogram to confirm if they do or don't have atrial fibrillation. In the old days, I'd have to send them to the lab and do an electrocardiogram, and maybe by the time they go there, it might have disappeared, what we call paroxysmal or intermittent atrial fibrillation. And sometimes we have to put on a 24-hour monitor that's going to check the pulse for a period of time to detect if there's intermittent atrial fibrillation with similar risks for strokes and for strokes. So we investigate with electrocardiograms done at the labs or in the hospital, the Holter monitor, an event monitor, or again, an exercise treadmill test. So an event monitor is like a Holter monitor, but instead of just carrying it around for 24 hours, the patient may have it for 14 days. And whenever they're feeling any symptoms or noting an irregularity, they'll press a button, and that will record the event so that we can tell what the rhythm is at that time. A Holter monitor is an electrocardiogram that's portable, and an individual can wear it for 24 hours after it's set up. And then the rhythm is actually interpreted by both a computer as well as a cardiologist to detect if there's significant extra beats or pauses or concerns. So the fourth type of heart disease is heart failure. So not the same as a heart attack, although heart attacks can result in heart failure. So heart failure is a decline in the pumping ability of the heart. So remember, the heart pumps blood to the rest of the body and takes blood back from the rest of the body and pumps it into the lungs. So in the normal heart, it's a normal ejection fraction from the left ventricle. And with various risk factors or with age, the damaged ventricle is no longer to pump out the same volume of blood up into the aorta to the rest of the body. So the symptoms of heart failure include fatigue, shortness of breath with physical activity, shortness of breath when you're lying flat, because blood is pooling back into the lungs, and when we're lying down, that blood from the extremities is going into the lungs. Or waking up at night short of breath and feeling better when you're sitting up again. Or just gaining weight, like gaining 5 pounds in a day or 10 pounds in a week could be fluid retention that might be related to heart failure. And edema, which is swelling of the feet or the legs. So when the blood's not being pumped out through the heart, it backs up through the veins down into the extremities. And the most common causes, other than aging itself, is high blood pressure and coronary atherosclerosis. So narrowing of the blood vessels that supply the heart muscle could damage that muscle and cause the ventricle not to contract as well. And high blood pressure increases the force that the heart has to contract against the resistance of the arterial blood pressure. The heart is working too hard for many years and fatigues, enlarges, and weakens. And again, other causes could be an irregular heart rhythm, like atrial fibrillation, or smoking that damages the blood vessels and the heart muscle, obesity, because there's more work for the heart to contract, thyroid disease, either under or overactive, and excessive alcohol that damages the heart muscle directly. We call it alcoholic cardiomyopathy. And there are other conditions that cause disease of the heart muscle that we call cardiomyopathy. It could be congenital, or it could be autoimmune, or just what we call idiopathic, no recognized causes. Other less common causes could be a viral infection. So people might have a flu or COVID, and that can cause a myocarditis and heart failure. There could be the side effect of some medications, like typically beta blockers. The non-selective type can affect the cardiac function as well. And certain metabolic conditions like over and underactive thyroid or iron overload, like your body has too much iron in the blood and it deposits into the heart muscle and prevents it from functioning normally. So we treat heart failure by controlling the causes, high blood pressure, all the risk factors for narrowing the arteries and diabetes. We adhere to a low salt diet, less than 2 grams of sodium in a day. And you'd be surprised at all the sources of sodium in our diet. A lot of our packaged and prepared foods are higher in sodium. Most of the takeout foods or delivery foods from Uber Eats are higher in sodium as well. So start looking at the labels, and when you're at a fast food restaurant, ask McDonald's or Burger King to give you the list of ingredients, fat content, and sodium in their different entrees. You want to reduce excessive alcohol, and as you now know, more than 2 drinks in a week is excessive. And to quit smoking if you do smoke. We use medications, selective beta blockers, a drug class called ACE inhibitors, and diuretics, which take off the extra fluid. And of course, we treat the reversible causes such as an over or underactive thyroid gland, anemia, which makes the heart work harder, and arrhythmias, which counteract the normal contraction of the heart muscles. So everyone with heart disease needs to know how to self-monitor. So all people with chronic conditions like diabetes, atherosclerosis, or other types of heart disease should have regular visits with their doctor where they actually answer any questions they have about their condition, talk about advanced directives if their conditions are to worsen, to get a good idea from their healthcare providers of what stage of chronic disease they have, and then what preparation you need to do, or what changes in your habits or routine should you do. And of course, practicing healthy eating, healthy physical activity that's appropriate for your condition. So, communicating with your doctor, either your family doctor, your nurse practitioner, emergency physicians, doctors you meet in the urgent care center or in the walk-in clinics. What is the key information you need to make a decision about a proposed treatment? So if it's an investigation, like an echocardiogram or a stress test, or if it's a new prescription or another type of treatment or surgery, we always need to know these 4 things for you to make an informed decision. So don't leave a clinic or office without having each of these questions answered to your satisfaction in plain English. So number 1, if I'm proposing a medication, I have to make it clear, what is it for? What's it supposed to be treating? This medication is supposed to help control your blood sugars. And how does it do that? Or this medication is for controlling your cholesterol. Or this medication is for controlling your blood pressure. And then the second question is, what are the common risks or side effects of this medication or treatment? For example, the common risk of most blood pressure medications are blood pressure is too low, you might feel dizzy and tired or lightheaded. And particular blood pressure medications might cause a cough, such as the ACE inhibitors. And the beta blockers may cause a lot of fatigue or even depression. So everything has side effects. So we should advise you of the common side effects, as well as number 3, the major risks or side effects. So what are the warning signs and what will those symptoms be? And are those risks that you're willing to accept? And then finally, what are the alternatives? What happens if I don't take these medications, or if there's another way of treating the same condition? So those are the 4 important things that, as a healthcare provider, I should be sharing with you if I'm proposing a particular treatment, investigation, or giving you a new prescription. What is it for? What are the common risks or side effects? What are the major risks or side effects? And what are the alternatives? Again, these are in your handout, and it's also in the handout for my talk on the doctor-patient relationship and improving communication with healthcare providers. So that gives you a good list of key questions to ask any healthcare provider. And in particular, for any drug, you need to know what it's for, and you need to know the potential interactions with other foods or other drugs you might be taking, or antibiotics you might be prescribed by another physician. You need to know both the brand name of the medication as well as generic name. It's kind of like a first and last name. Too often, patients will just memorize the first part of the name, which is usually the generic brand manufacturer, which just is common with many, many different drugs. So try to learn more than APO, or Teva, or Mint. These are common generic drug manufacturers, and they each have hundreds of drugs. So you don't want to just learn the prefix, but learn the full name of the drug. So the brand name in its complete form, so what comes after the hyphen, as well as the generic name, the name of the molecule. So it's good to have both of them written down. So ask your pharmacist or your family physician to print out the list for you if you have any questions. You need to know the dose, the milligram size, for example, and the frequency, how often you're supposed to be using it. So if you're taking a number of drugs, it's really useful just to have them all, an updated list in your pocket or wallet that lists all your medications with these 4 key bits of information. So just in case you didn't bring your whole bottle of pills with you, it's quite clear to anyone that's looking after you what you're taking in case you go to a walk-in clinic or to an emergency department. And if you're going to see an unfamiliar physician, these are the key things you should know from your medical history. So also in your pocket. And your family physician actually keeps all of these in your chart. It used to be in the old paper charts in the olden days. This would be the face page that we look at every time we open the chart. So in our computer records, it actually is on the side of our chart that we're looking at when we're dealing with the problem that you're bringing into the office. So I can see at a glance what your allergies are. I can look back to see what your family history is. I have a list of important hospitalizations and what they were for, major illnesses, any operations you've had, some special procedures like an angiogram or a valve replacement, and other important investigations. And fourthly, you need to know about chronic medical conditions that might include peripheral vascular disease, diabetes, high blood pressure, chronic lung disease, asthma, and any medications you might be taking. So these are the 5 key things that you might have as a 1-pager. And if you're older or more complicated, a 2-pager in your pocket, in your wallet, in your purse, that should be with you at all times in case you end up in an emergency or call an ambulance. So at your fingertips and at the fingertips of the people that are looking after you. If you have already discussed advanced directives, like what you would want done in certain conditions. So if you're at a particular age or stage of health where, for example, if you're in your 80s or other chronic conditions, or if you have a condition that's incurable with a shortened life expectancy, you might choose not to be resuscitated if you were to collapse in the hospital and not regain consciousness. Would you want CPR or defibrillation? So if you don't, then you would want to indicate that you do not want to be resuscitated or do DNR. And you might choose that you wouldn't want to be in an intensive care unit and be on, or not have a feeding tube or on a respirator to breathe. Again, before you make a decision, it's something you should speak to a healthcare provider that you know over time. So we could talk about the risks and benefits of all these procedures and whether you feel it's appropriate in your condition. So it requires a discussion with your family physician. And if you have made a particular decision, it's important to include that in the medical history that you're carrying with you and then update it regularly. And if you're encountering an unfamiliar physician, that is a physician that's not familiar with you, and you think that the doctor might have rushed a little bit too fast and might have the wrong diagnosis, here's some key questions you can ask the doctor. What else could it be, doctor? Because when we're taking a medical history, we're listening carefully and asking key questions to rule in and rule out different conditions. So when we ask ourselves what else this could be, I'm always thinking about what's the worst thing that it could be. And I always think about what I would recommend for a best friend or family member. So my rule of family practice and family medicine is to treat every patient as I would want a best friend or a family member treated. So the same degree of thought, investigation, the same specialist that I would refer to, and the same speed of response that I can get for getting tests done, like a mammogram or an exercise stress test if we can. So asking that question of a physician or a nurse that's treating you, what would you recommend to your mother or child, that personalizes things and makes us reflect to make sure that we're giving you that same level of care and thought. And it's so easy when you're rushing in a clinic or in the emergency, it might be easy to jump to the most obvious solution to what the problem might be. But we also want to keep in mind that could this be the signs of a stroke, or could this be the signs of a heart attack rather than heartburn? What's the worst thing could be, and what should I do to rule it out? So three key questions that you can ask a physician, and then it gets us to open up that funnel and open up the differential diagnosis so that we're not skipping things over or missing information. So your heart is a muscle that improves with training. So we can train our heart at any age. We can't change our chronological age, but we can improve our physiologic age. And I think the challenge is, how fit can you be right now? And I believe that we each have a unique potential in life, and it's our duty to realize that potential. That's your gift to the world. And the other gift is to help others achieve theirs. And with knowledge, engagement, and support, we can manage chronic health conditions and all live well. And if you do have a chronic health condition, you're not alone. In fact, there is the most common chronic condition, and every one of you and I have this condition. It is incurable, it is sexually transmitted, and it has 100% mortality. Can you guess what it is? Yes, that chronic condition is life. So let's make the most of it. So I'd like you to share anything you found useful to the people that you care about with your neighbors, anyone that you would find useful, and I invite you to attend our other empowering patient talks. I think I made a note of our next talk on March 9th on my dad's birthday, on my dad's 93rd birthday. I'm talking a brand new presentation on chronic lung disease and acute lung disease. So what you should know about lung disease, including asthma, infections, pneumonia, and chronic bronchitis or emphysema. So how to recognize that and just the basics of how they are treated as well. So I think I ended just in time to answer any questions that anyone might have.
Hey, hi everybody. So I've got no questions in the chat as of yet, but now's your time. We have a few extra minutes. So hi Sheena, nice to see you. So yeah, please pop your questions in. I can, here's one. Where does hypertrophic cardiomyopathy fit in the list of types of heart disease?
Yeah, so it's a common cause of heart disease. So Hypertrophic cardiomyopathy. So cardiomyopathy is an abnormality of the heart muscle, and hypertrophic means it's a super thick, dense muscle. So it affects the ability to pump that blood to the rest of the heart. And it's a common inherited condition. For example, one of my patients was recently diagnosed with it. So we're actually screening all his siblings and each of his children with echocardiograms. And I treat a large number of his families over looking into it just to make sure they don't have it so we can identify it early. But it's treated much like heart failure, but it is one that is idiopathic. We don't recognize a particular cause, and it's not due to smoking and other risk factors for other types of heart disease.
Great. Can COVID affect heart health?
Definitely. So COVID, it affects everyone differently, but it can cause inflammation in pretty well any organ in the body, including the brain and the heart. So it has been a cause for myocarditis or inflammation of the heart. And that can result in heart failure or chest pain and abnormal cardiac tests. And it could be temporary, or it could be longer lasting.
Great, thank you. What is an upside down T wave, and is it concerning?
So T wave inversion is an abnormality in electrical conduction. So it could be a sign of damage to the heart muscle or more of an electrical problem. So it could be a symptom of narrowing of the arteries. So as heart muscle is affected, it affects the electrical signal. So that's amazing what we can learn from just an electrocardiogram.
Excellent. So Craig says, thank you for the presentation. It comes on the 71st anniversary of his paternal grandfather dropping dead from a heart attack. Sorry to hear. The question is, have Apple Watches made people more aware of cardiac health or created more needless work for doctors to deal with hypochondriacs?
Actually, I haven't had one hypochondriac come in with their Apple Watch tracings. Actually, it's always been useful. So it's actually been a really useful thing. And I find, as I showed you, it's actually handy in the office, so I don't have to send the patient for an EKG right away or worry that it's going to change by the time they get there. I could check on the spot for the arrhythmia. So I think it's been really useful. It's been great during the pandemic where people can check their oxygen saturation. Because even our pulse oximeters that we have in the office, we have to keep new batteries in them all the time. But people are always charging up their Apple Watches or their Garmins that can detect these things for them. So I think it's really useful. And it's been really good for people exercising within a safe heart rate range for their age and their fitness level. So it's actually been a useful thing, although too expensive for most people to have.
Yeah, that's great. Do blood clots occur in non-narrowed vessels, and would it even be noticeable?
Well, you can get blood clots where there's not good blood flow or where a blood vessel is narrowed. So it's really if there's narrowing of the artery due to cholesterol building up inside an artery, it's easy for the platelets, which are the blood cells that form clots, to aggregate and clump together. So if there's an irregularity of that blood vessel, rather than one that's nicely well open, then it's less likely for a clot to form. So this is a little bit different from venous thrombosis. You know, when someone gets pain in their calf, that's a risk factor for a blood clot that goes to the lungs, what we call a pulmonary embolism. And the risk factors could be cancer, damage to the blood vessels, or a long trip or airplane ride where the blood's not moving. So a blood clot can form there in the leg. So if you get leg swelling and pain, that could be a symptom of a blood clot. So you'd want to check in with a healthcare provider to make sure. We check that with a blood test and then sometimes an ultrasound of the extremity.
Great, thank you. Can hypertensive people jog or run?
Yes. So actually, jogging, running, cardiac exercise is a really helpful way to lower the blood pressure. But you should check with your physician if you have extreme hypertension. During exercise itself, your blood pressure will go up. So that if you have very high uncontrolled blood pressure, your family physician may send you for an exercise treadmill test, because if we can see how the hypertensive response is when you're exercising, to make sure it's not exaggerated. And then we can give you a safe heart range that you can go through so you can tell if it's safe for you to continue exercising. So when my parents were 10 years younger than I am right now, they were both taking blood pressure medication. So I have the genetic risk factors for diabetes, high cholesterol, and high blood pressure. But my blood pressure is usually below 110 for the top number, so a little bit lower than average, because I started about 20 years ago doing hard cardio exercise every single day. So I do an hour of cardio 7 days a week, except for Christmas Day when the swimming pools aren't open. And that's actually controlled my blood sugars to normal and kept body fat down and gives me a slow heart rate and a low blood pressure and lower than normal cholesterol as well. So in spite of genetics give you a clue of what your risk factors might be, so you know what to check with your physician, but it can guide you in the lifestyle management and in preventing these diseases as well.
Right. I think this leads into the next question then. How often should you get a stress test if you have a family history of heart disease?
That's something to talk over with your physician, because if you're managing all the risk factors well and you have no symptoms and you're still young, you don't have to do it regularly. But it depends on the risk factor analysis that your family physician, or if you have a cardiologist, that can determine. So it depends on your fitness level and the management of your risk factors.
Okay, great. Can you comment on premature ventricle contraction?
Yeah, so the early beats or extra beats that can be thrown in that are not atrial fibrillation are either coming from an atrium, the smaller chamber of the heart, or the ventricle. So a premature atrial contraction is an extra beat thrown in to the regular sinus rhythm contraction of the atrium, followed by the ventricle. So a PAC is a premature contraction from the small chamber, the atrium, and a PVC is an extra beat thrown in by the larger chamber, the ventricle.
Okay. Is it advisable to cut down on sugar and coffee if there is high cholesterol?
Not necessarily. So coffee by itself doesn't usually raise cholesterol unless you're putting lots of cream into it. And sugar itself doesn't raise cholesterol, like the bad cholesterol, but it might raise the triglycerides, another type of molecule that's measured when you do a full cholesterol lipid panel.
Okay. This one is a person's 52 years old and is getting dizzy and nauseated. She's had blood pressure and heartbeat checked, but and doctor said that's normal. Is it because of anxiety or something from COVID?
Well, individual questions that we can't really answer because we don't know all of your medical history. So without doing that, there could be many, many different things. So you'd have to rely on your family physician or your specialist physician that has all the information and ruled out the most important things. So there's a large variety, a big differential, and it would be malpractice to try to diagnose that at the end of a webinar without full information.
Sounds good. What's the other food you recommend to reduce cholesterol, LDL, besides salmon and avocado? Perhaps take supplements like flaxseed oil, seeds or oil?
Well, you had actually mentioned the good types of fats. So there are the saturated fats that are a large amount is actually from animal products like beef, lamb, and pork. They're higher in saturated fats that get converted to the bad cholesterol, LDL. See, one of my patients remembers it by thinking lousy cholesterol, LDL cholesterol. So it can come from really high fat dairy products like lots of fried foods. So eating less of those foods and replacing them with healthier fats like polyunsaturated fats, or such as olive oil. Canola oil is a bit better. Nuts and seeds are generally good. Avocado is great for a healthy fat, and fish oils, omega-3 and omega-6 supplements, they all raise the HDL, the healthy cholesterol, so they protect our arteries. Oh, and exercise also raises the HDL, or the happy or healthy cholesterol, as my patient said.
That's what we like. That's what we like. That's it for questions, unless anybody, we have a couple minutes. If anybody has any more, you want to pop them in the chat,
Any
but we're getting
COVID
lots of thank yous.
Oh, great. Thank you. And thanks for spending time with us this evening. And I hope I've clarified your questions and made you a lay expert in heart disease. So you know what valvular heart disease and what the symptoms could be. Recognize both typical and atypical symptoms of a heart attack or angina. And just so that you know what questions to ask your physician or healthcare provider next time you see them, so they can evaluate your risk for these conditions as well. And I wish each of you to achieve your positive potential and to help the people in your life achieve theirs as well.
Oh,
Yeah,
actually, somebody said that they use their Apple Watch ECG feature all the time. So that's great.
that's good. I hope you don't have any heart problem.
Exactly. Well, I think that covers it. We do have as soon as I close down the webinar, little 8 questions are going to pop up, and that's just a post-event evaluation that we do. So please feel free to answer the questions honestly. If you want to receive information about upcoming events, upcoming talks, Walk with Your Doc has been now officially scheduled in Burnaby for May the 6th. So hopefully we'll see you there. If you'd like to receive that type of information from me, please fill out the form. There's an opportunity to share your email if you're not already on our email list.
Yeah, the Walk with Our Doc is something Leon and I look forward to because we organize it together, and that's when we get to see all of you in person. So every one of you has a personal invitation to come to the Walk with Your Doc. It's a free event, and it's a real feel-good event. And our Mayor Hurley has been coming to it every time since he's been a mayor. So he's often a guest of honor and a great role model for our community. And a lot of our family doctors come out and show that we care about each of you. We care about our community. And of course, we care about our patients, and we walk the talk. And thanks, Leona, for being our gracious, wonderful host to make these talks possible.
Oh, it's my pleasure. I love it. So I did put quite a few links in the chat if you want to take a quick look before we go, just about all the work that's happening in Burnaby, services and resources that are available for Burnaby family doctors and nurse practitioners and for you. So there's a lot going on. Please check out those links. And maybe we'll see you at the Mr. Wong's birthday talk on, what was it?
March 9th.
March 9th. That'll be a good one.
My dad is excused in case he's going to some party.
Well, that's true. He may have other plans.
We're gonna have to do the party that ends at 7 o'clock.
Well, there you go. Maybe he'll be okay with that. Excellent. All right. Well, if there's nothing else, I'll let Dr. Wong go. I'm sure he's now got some paperwork or something to do to end his day.
Okay. Thanks again, Leona.
Take care, guys. Bye-bye.